Hi friends, I am Dr. Akash Khandelwal, Senior Consultant, HOD, Department of Hematology, Hemato-Oncology, Bone Marrow Transplant and CAR T-cell therapy at Fortis Hospital Shalimar Bagh. Today we'll be discussing about all the nitty-gritties and all things that are worth discussing for multiple myeloma. Let's start.
Thank you, sir. And so we'll start with the first question. So, for someone who has just been diagnosed with multiple myeloma and has no medical background, how would you explain what multiple myeloma actually is in the simplest way possible?
To understand multiple myeloma, it is a very unique disease, to be honest. It actually starts inside your bone marrow, which also leads to involvement of your bone, eventually your kidneys and your immune system and other body organs as well. So it's a very unique disease that way in design because it's a multi-systemic involvement can be there even at the presentation. Some patients can have only bone pain, others might have only anemia, some others might only involve kidneys. Most of the time, what we see is multiple organs are involved by the time patient presents to us in the clinic. So it's a very varied disease and pretty unique in that way. So whenever in a common man, if you are suffering from undiagnosed anemia and unexplained kidney disorder, unexplained pains or weight loss, that warrants an evaluation by a hematologist.
So, the next question would be like, what are the early warning signs of a multiple myeloma that patients and family often overlook or mistake for something else? And how long does it typically take from, symptoms to a confirmed diagnosis?
So yeah, so multiple myeloma, if we see by disease per se, it's a slow growing disease. It has various stages. This problem starts from plasma cell proliferation, leading to something called as monoclonal gammopathy of unknown significance. Then there could be a smoldering myeloma phase, and then there could be a myeloma. So it can take years before presenting itself. So therefore, it's a challenge to identify it upfront. But there could be few signs and symptoms like unexplained bone pains, weight loss. A lot of time patients visit hospitals with pains, go to an orthopedic. They can be diagnosed with fractures, probably because of age, but sometimes the story is beyond that, and it's probably myeloma hiding inside those problems. Similarly, unexplained anemias can be there, recurrent blood transfusions, hemoglobin low, leading to weakness, fatigue, sometimes blood transfusions as well. Also, it can also present as unexplained kidney problems with anemia, new onset kidney problems, not really attributed to anything. Again, one should be evaluating for myeloma, or else patients sometimes just keep on taking some kidney medication and even dialysis. They are still undiagnosed. But let me be very clear, if kidneys are involved, it is completely salvageable. So you should not be ending up with dialysis. Therefore, early evaluation is very important in such scenarios.
All right, sir.
Other presentations of myeloma are very rare, but these are the most common ones, and one should be, varied and alert if it's a recurrent problem, long-standing backache, consistent weight loss, kidney problems, new onset, unexplained anemias. These are something which warrants evaluation.
The next question is like, we hear that multiple myeloma affects the immune system severely. So, can you explain, like, in terms why a multiple myeloma patient becomes so vulnerable to infections?
This is normal design of the body. If the body is not used, if body's organs or cells are not being used for fruitful things, it will cause devastation. And in this case, the plasma cells are haywire. They are not really helping you to treat any infections. They are just there and they are increased in number, causing other problems and not doing their actual work. So this is the main reason why there is a risk of infections even without treatment and with treatment of myeloma, because the plasma cells get the intensity of plasma cells in the body get reduced, leading to proneness for infections even then. So it's a double-edged sword even with treatment as well.
So, can you help our audience understand why bones are affected? Like, what is the connection between myeloma cells and bone destruction? And why do patients experience so much bone pain?
So yeah, this is kind of interesting. So this plasma cells that we talked about briefly, these plasma cells which divide in number and reach to a certain extent where it causes problem, they also have something called as rank ligand and activates rank ligand, which is there on bone. which causes these punched out lesions or breakdown or osteoporosis of these bones. So this is all expressed via the plasma cell proliferation itself, which happens inside the bone marrow, leading to such unique problems. No other disease have these features, but specifically this myeloma cells have these ligands which activate osteoporosis or lytic lesions or hemophagocytosis of the bone cells, the osteoclasts.
All right.
Activity increases leading to these problems.
So we know that not all multiple myeloma cases behave the same way. Some are very aggressive while other progress slowly. So what is the biology of the cancer cell, chromosomal changes, or there are gene mutation, that makes one patient disease more aggressive than others?
Genetic implications of myeloma are very important because sometimes we even see patients having M band, but there are no other symptoms, which is actually an MGS or a small tract myeloma taking years for proliferation and any changes for fitting in the category of multiple myeloma. But others they are very hostile and can be very aggressive even with treatment. The major causes are some genes which we have known and some reasons are still unknown. But the new known reasons are high risk genetic factors like 17p deletion, double hit lymphomas, 4, 14, 14, 16 related mutations, 1q gain, 1q amplification, or multiple genes present which do not favor good prognosis. These are high risk features and can attribute to aggressive nature of myeloma.
So, multiple myeloma has like different stages and risk categories, high risk, standard risk. How does the stage or risk category affect the treatment plan, and specifically who qualifies for a bone marrow transplant?
Treatment of multiple myeloma is a marathon. Coming to this risk stratification and treatment decisions. So initially it was sought out to be that the standard risk treatment might be less aggressive when compared to a high risk disease, but that's no longer the case. We have seen down the line that even with a standard risk disease, if he's treated aggressively, they have better outcomes than if they are not treated aggressively. So the common consensus is to treat them upfront with the best possible treatment and consolidate with a bone marrow transplant, even irrespective of the risk category. If the patient still behaves aggressively, then it's actually a truly a very high risk disease that even with the best of treatment, the disease is not under control. So that is now the ideal definition of a very aggressive disease, or if it's a double hit or a very 17p deleted or two mutations which are high risk, they really categorize and they are really once we really feel requires more attention rather than just category of standard and high risk. So in short, we tend to treat them aggressively upfront and to get the best outcome.
Doctor, we keep hearing the term bispecific monoclonal antibodies in the context of multiple myeloma treatment. Like, is this the treatment of the future? And if you could please tell me like the basic or like a simplest way, what is bispecific antibodies and how it is different from a
So
regular treatment?
bispecifics are amazing. They are truly are. They are amazing. They are definitely the future, and even the present now. We are getting more and more data of biospecific usage upfront or in a first line post relapse, and they have shown wonderful outcomes. So bispecificity really works is by the fact that it have two bi means two, right? So it have two targets. One is on the plasma cell, which could be a BCMA or a GPCR5D target on a plasma cell, and another one on immunity, could be a CD3 mediated one. So this is which is currently available. It's a CD3 and BCMA bispecific, which acts on T cells and BCMA expressions, which is there on almost all plasma cells, and causes less expression of that, leading to best outcomes and reduction of plasma cell to a level where we can even achieve a very good complete responses and stringent CRs. Though we don't have much of data, but looking at how impressive they are, they can even give us a cure to multiple myeloma which is really unheard of till now.
So, like, who are the ideal patient for bispecific antibody therapy? And like, is this for newly diagnosed patient, or it is specifically for patient who disease has came back after previous treatments?
So we don't have much data for upfront use of bispecific as a first line in a newly diagnosed case, but with time we'll get that. So that is still unanswered. But in a relapse setting, in a first relapse, they are truly wonderful because they have shown very effective response rates. And 2 years progression free survival is somewhere close to 80-90%, which is very high for any kind of treatment seen before for a myeloma. So yeah, definitely those patients in a relapse setting, we are started offering bispecifics for them.
So, moving on to the next question, why can't we, just continue with the chemotherapy, like for patient indefinitely, instead of going, for the BMT for the patient?
We can explain you this by explaining weapons. If you are in a battlefield and you're just using swords, you cannot really win a fight. You have to use other weapons to get the best and good outcomes. Similar to this, using the same chemotherapies again and again has a limit to it. You will not achieve the best outcomes by using only one kind of treatment for multiple myeloma. Therefore, bispecifics are so good because it's a unique and a different way of treating myelomas. So similarly, just chemotherapies will give you good responses, but cannot give you an endless response where everything works well for you over a period of time. Because as I said, marathon treatment is required in a multiple myeloma as it's not really curative and can be controlled. So down the line, what we have seen is if we are not using transplants or other methods, then the disease tends to come back, and such diseases are aggressive. So it's better to give all the treatment that we have, which is generally chemotherapy for now, along with daratumumab, followed by an autologous transplant, and just maintenance after that. These pair the best of results for such individuals rather than just using chemotherapy uh, down the line. And when you use chemotherapy for such long times, it will have lot of side effects. If initial 4 6 months doesn't really impact your health, but if you continue to use chemotherapies beyond 1 year, it generally have ill effects on your body, and you don't really get uh, you know uh, best of responses. And morbidity wise, it also is pretty morbid sometimes because you come catch infections, other neuropathy, weakness, fatigue, diarrhea. These things tend to happen when chemotherapy is used for a long time. So yeah, so it's not really indicated in any kind of guideline to just continue chemotherapy. Uh, Everybody tries to use bone marrow transplant for better and the best outcome for the patients. Of course, if he's unfit for a transplant because transplants can be intensive, then we only have this chemotherapy option. But yeah, the outcomes are relatively lower.
For our audience, can you please, explain in a simple term, like what is autologous bone marrow transplant, how it works, and why it is used in multiple myeloma treatment?
The autologous transplant is provides us the opportunity to reduce the plasma cells to very traces in the volume and amount. Though it we know that plasma cells cannot be eradicated as such because these are part of your body system. But the idea is to control the disease and then collect your stem cells, and then whatever plasma cells are left in the body, they are eliminated with the help of chemotherapy. This is high dose chemotherapy, and since you are killing off all the cells, you need stem cells. So the stem cells are retransfused in the body as a rescue mechanism, and it tends to start proliferating after 7 to 10 days. So in this is what is ideally is an autologous bone marrow transplant, which offers a very unique way to get the desired outcomes of a long term remission. Though, again, as I said, it's not possible to eradicate plasma cells completely, but there is a good progression free survival that one can achieve after an autologous bone marrow transplant.
So, what does complete remission mean in multiple myeloma after BMT? Does remission mean the patient is cured, or does the disease always come back eventually?
90% of the disease come back, some sooner, some later. But our goals currently were to just push the disease to as long as possible for it to reduce the risk of relapses. So similarly, 90% do come back sometimes, some early, some late. And what was the second question?
Does remission means the patient is cured, or does the disease always come back eventually?
Remission means, see, remission is a word that is used for the current scenario, that you can say that currently your disease is inactive or it's not there, but that doesn't guarantee anything that cannot re-arise or, come back after 6 months, 1 year. So that is just a current perspective that is being told when one uses the remission word. And by remission, one means that he is currently well under control. A complete remission means that plasma cells are not there. A stringent complete remission means that the plasma cells were checked by a flow cytometry and was not there currently in the system. The I'm talking about those plasma cells which are cancergen, not the normal one.
So, what are the most common side effects and complication a patient should be prepared for during and immediately after the BMT procedure? So, what is the medical team, doing to manage these complications?
Immediately one patient is admitted, as I said, if we are using a very high dose chemotherapy, all the cells tends to die, leading to low platelets, low hemoglobin, low immunity. So one has to need to transfuse blood, platelets, and one can have infections leading to antibiotic use, and also patients have nausea, vomiting, diarrhea, oral ulcers, and hair fall. This is to like bound to happen as because your cell dies, and then only the new cells kick in. So this phase have to be countered, and this phase is there for 4 5 days, and generally after that the patient feels better. But yes, the immunity is restarted, and the immunity is as of a child. So the immunity is relatively new, and one has to be very careful in public, just like a child. But after 3 months post transplants, things are much, much, much better, and patients can do their daily activity. One also has to start vaccination after 6 months of bone marrow transplant, and also maintenance with single agent or a multi two agent drugs are started. Oral treatments are preferred 3 months post transplant to maintain the response for adequate outcomes.
We have like almost last few questions. So, there is a question that the patient usually asks, like whether it is an hereditary disease, or should my children or sibling, get tested? How do you answer this?
Well, it's not really an hereditary disease, multiple myeloma, but there is a relative risk, rise of relative risk amongst family members of getting any kind of cancer if one has any history in family. But it's not really transferable or a genetic disease to begin with.
Thank you, sir, for giving your time and explaining in detail about multiple myeloma and all the treatment and the future treatment of multiple myeloma. Thank you so much once again for giving your time.
All right. Pleasure, pleasure. Thank you.